All right, next up, we will have a presentation by Dr. Nguyen. He's the head of department of Vinmec Hospital in Vietnam. And this is the leading center for treating implantation failure. They have a success rate of about 50%. He is also a leader in endoscopic technique and research on the cause of implantation failure. So let's welcome Dr. Nguyen as he discusses his strategy when treating recurrent implantation failure. Welcome, doctor.
Okay, good afternoon. Do you hear me well?
Yes, good afternoon.
Okay, thank you very much for the invitation, and it's my pleasure to be here with you today, this afternoon, to present our experience in IVF Center in Vinmec Hospital, Hanoi, Vietnam.
Thank you. Let's start.
Okay, my topic today is about recurrent implantation failure and our strategy in Vinmec ART Center. So we have been talking about it for many years, but it still remains a strong problem for quite all IVF teams in the world. And we have a different definition, but we all agree that one patient with 2 or 3 transfers without pregnancy, we are facing a kind of risk. So this problem is difficult and is multifactorial, and why all guidelines recommend to perform a full checkup. So what is this checkup in our center? As you can see in these screens, in this slide, we check 3 main points in a couple with RIF. The first one, as all we already know, we should have a good quality embryos. So in our center, we are doing day 5 culture quite in all of our patients, and we are incorporating also a time-lapse technique to select the best embryo. And in selected cases, with indication, we also perform PGTA to choose the best embryo. So that is to have the quality embryo guarantee. And we also check for uterine abnormality, for example, anatomy abnormality like myoma, polyps, endometritis, or synecia, and especially we have an increasing number of patients with secondary infertility due to ECMO cells, because in Vietnam we have a quite high rate of cesarean section. And normally with the couple, with the patient with RIF, we perform hysteroscopy, diagnostic hysteroscopy, and operative hysteroscopy. In diagnostic hysteroscopy, we perform endometrial biopsy. We look at if the patient has endometritis. And also, we check for the general condition in both men and women. In the men, we check for karyotype, DNA fragmentation, and MTHFR. And in the woman, we check also for karyotyping, antiphospholipid syndrome, and autoimmunity problem like anti-TPO, anti-TG, and MTHFR also. And we are focusing recently, especially 2 years ago, in endometrial and receptivity. And for that, we are performing 2 kinds of tests. First of them is ERA test in cooperation with Igenomix Japan. And the second test that we are doing in our RIF cases to check for endometrial and receptivity is called Matri lab in cooperation with a lab in Paris, France. So in this step, we check for immunity problem. And ERA test, and you already know about this with the other speakers, and we are going to talk about this in more detail about cases in the later slides. And for investigation of uterine anatomy, we use also a classical technique like hysterosonography, ultrasonography, and hysterosonography, and we are using diagnostic hysteroscopy in quite all cases with RIF. and operative in case necessary if we find some anomaly. And we use MRI also in some selected cases for diagnosis. In diagnostic hysteroscopy, we check anatomical normality of uterine cavity. It means morphology, tubo-osteus, abnormality like myoma, polyps, inmost cells, as I already said in my previous slide. And we check endometrial aspect for thickness, inflammation, and adenomyosis. And we perform normally endometrial biopsy, and we perform study in histology, immunology, and in operative surgery with hysteroscope. We perform polypectomy, keratitis of hyperplasia, adhesion resection, and also resection of myomas that deforming uterine cavity. And we are doing more and more repair of inmost cells, as I already said in the previous slide. That we are facing an increasing number of patients with secondary infertility and rift due to inmost cell. And we already know that in chronic endometritis is present in a high percentage of patients with rift. And in this disease, we have interaction of bacteria with endometrial microenvironment that cause a negative impact on endometrial receptivity and promotes changes in leukocyte population, cytokine production, and growth factors. And to diagnose chronic endometritis, we use diagnostic hysteroscopy, and we perform biopsy, and we check for histology and immunohistochemistry. We also perform microbial and molecular microbiology. And this is a classic image of a chronic endometritis under diagnostic hysteroscopy. And we order for immunochemistry with antibody CD138, and it gives us a specific diagnosis of endometritis if we have more than one plasmocyte in a count. And in molecular microbiology with NGS technology, we perform DNA extraction and amplification and separation of human tissue from bacteria, and we could give identification for 9 kinds of bacteria. The most frequent bacteria that we found in chronic endometritis in our patient could be Enterococcus species, Escherichia coli, Klebsiella pneumoniae, or Staphylococcus species, also Gardnerella vaginalis. And with this, our patient with chronic endometritis with antibiotic, either doxycycline, azithromycin, or combination between quinolone and metronidazole, according to the guideline. And about ERATF, and we already know that with ERATF, we look at the implantation window, and we are talking more and more about that worldwide, and specifically in this congress. In this step, we check for gene expression and to know about the endometrial receptivity. And if in the present and in the future, we should look at the microbiome. And we know that in the uterine cavity, previously we thought that is sterile, but in fact, we can detect microorganism. It's called endometrial microbiome. And the deep biopsy of uterine cavity could be the cause of poor reproductive outcome. And pathogenic deviation of lactobacillus endometrial content could play an important role in infertility. And in cooperation with Igenomix, we check for endometrial microbiota profile. And if there's some abnormality, some dysbiosis, or some germ, we found some germ, we could give the patient probiotic or antibiotic therapy. And with that, we hope to improve the outcome in our patient. And talking about recurrent implantation failure in the future, we think that the implantation failure clinic, the test should include serum progesterone, ultrasound, vitamin D, ERA test, immune cell counting, histology, and microbiome. And in women with risk, it's demonstrated that we found a higher prevalence of chronic endometritis, a lower mean level of vitamin D, and lower mean my-Lutein progesterone, and no difference in display ERA test result. And this is our ERA test result. The GEO test, it means that in cooperation with Igenomix APAC, we have been sending until now, not many cases, but 15 cases. You can look at the table that we check for implantation window, we check for microbiome, and we check for infection in the endometrium as well. And in totally 15 patients, the outcome is following. So after embryo transfer, we have a successful rate, it's 45.6. It means 5K over 11 cases a patient, and 4 cases not transfer, yes. Of course, the number of patients is not very high, but this can give us an idea of the outcome when we apply the Igenomix protocol for the cases with risk. And we have in totally receptive result is why 50%, 7 over 15 patients, and the other are pre-receptive or post-receptive. And we found with Igenomix GEO test, low biomass is predominant in quite all cases, and ALICE test is negative in all cases. And on the cases had more than 3 transfer previously, it means that we are indicating GEO test for patients with risk, very difficult case. And to validate our result, we have the honor to participate with Igenomix in a study in a large randomized control trial that we are going to participate in this study. We have 2 groups of patients. One of them we will not do ERA test, and the other group we are going to perform ERA test, and we are going to compare the transfer of embryo after PGTA in the ERA test group and in non-ERA test group, and we're going to compare the result. And finally, we hope to have a clearer view about the effectiveness of ERA test in personalized embryo transfer. And let me show you our result in immunological endometrial receptivity also, because in the previous slide I talked that we cooperate with Matching Lab in Paris to check for receptivity, but from immunological aspect, because we know that if the patient has immunological problem, so it could enter and cause problem in the receptivity. That an important process that allowing normal embryo to implant. This is very classic slide that we know about the process step by step, requiring an endometrial site. And when we put back the embryo inside the uterine cavity, we have an initial transitory seroinflammatory reaction, and followed by establishment of local tolerant dominant environment. And in this step, they check for uterine natural killer cell, and also the secretion like cytokine and interleukin. We know that during the implantation, uterine natural killer cells are mobilized, and they are increasing in number, and the activation produces tolerance that allow the embryo to implant in the endometrium. And in this slide, we know that there are two kinds of natural killer cell. One of them is circulating, and the other that we look at is uterine natural killer. They have the secretion of angiogenic cytokine and normally low dormant cytotoxic potential. And in this slide, if we follow the menstrual cycle, we know that the number of uterine natural killer cells is increasing during the cycle until the maximum amount is in first trimester of pregnancy. And to perform the biopsy, we do quite the same procedure like with ERA tests in the day 21 to day 24 of the endometrial cycle. And in this step, we count the number of uterine natural killer with CD56 marker and cytokinic expression. It means the proportion between interleukin 18 and 20 and the proportion between interleukin 15 and FN14 by microarray technique. And we have three different scenarios. The first group is low local immune activation. And in this group, we have some strategies to achieve the local immune activation. By local injury is so-called very famous scratching, and we apply mild ovarian stimulation in the group of patients and supplementation with low dose of HCG, and we recommend sexual intercourse the day before and after embryo transfer. And we have another group with local overimmune activation, and in this group we have a different protocol. We recommend no local injury on endometrium, standard ovarian stimulation, adjunction of estrogen and high dose of progesterone in the luteal phase, and adjunction of anti-inflammatory adjuvant with antioxidant like vitamin A, and especially very important in this protocol, we use corticoid like prednisone in a dose of 20 milligrams per day. This is the first line of treatment, and we do not recommend sexual intercourse just before and after embryo transfer. And with the protocol, this steps called Matrilab, we have been doing 2 years ago, and we have done in totally 114 cases, and in total 112 biopsies suitable for analysis, and we have transferred 95 patients under this kind of protocol, and we have primary infertility 63.7% and secondary infertility 36.3%, and median number years of infertility quite 6 years of infertility, and previous embryo transfer quite 4 times, and number of embryo previously transferred is quite 10 embryos. And you can see that we have abnormal immunological problems in why 77.7% of patients is with dysregulations. And we have the reason as following: in 77 patients with immunological dysregulation, we perform embryo transfer under Matrilab specific protocol. We have achieved 43 clinical pregnancies with 31 deliveries and 9 ongoing pregnancies. So it's quite good result. And to finish my presentation, I would like to present with you one special patient. This one is very long story of infertility. She had unexplained primary infertility, history of 5-time IUI, 2 IVF cycle in 2 different hospitals, and until 2017 she had totally 9 embryo transferred. We perform hysteroscopy, diagnostic normal. We perform Matrilab. It's a mixed protocol, mixed result. And in 2018, we perform embryo transfer 2 times under Matrilab protocol, and only 1 biochemical pregnancy not successful. And in 2018, we perform to her new IVF cycle. We achieved 17 oocyte and 17 embryo frozen on day 3. And after that, we decided to indicate error test for her. And you see in the screen, we have the first result is post-receptive, and according to Igenomix recommendation, we perform the second error test to her, and with 4 days of progesterone, the result was receptive. And in 2020, we performed embryo transfer with scratching before cortisone antibiotic, tetrafolic, and frozen embryo transfer at progesterone plus 4. It's been 4 days of progesterone, and we control progesterone-elutant phase, and she gave birth successfully a twin pregnancy in August of 2020. So, coming back to recurrent implantation failure, we know that before coming on, patient with RIF have supported a very hard and long and expensive pathway to obtain a baby. So, with all the couple with diagnosis of RIF, we must to propose a checklist. It's our checklist that we usually do with our patient that I presented in the first slide to control every step in this implantation process. And on the exploration, we provide basic for more rational clinical approach and avoid blind intervention. And we must understand why we do and what we are doing. However, our knowledge about implantation is still incomplete, and we keep a lot to learn, and we have to remain modest and try to give to our patients the best result. So thank you very much for the attention.
Thank you very much, Dr. Nguyen, for your nice presentation. Due to time, I will again only ask one question that arrived for us. The question for you is, among all causes, which causes do you think that contribute the most to recurrent implantation failure in your patients?
Thank you for the questions. In my opinion, the 3 main causes. The first one is the embryo quality. So that in our patient with RIF, we focus on firstly on the embryo quality, which means we recommend day 5 embryo transfer, maybe with PGTA and time lapse. And the second main cause of RIF is that endometrial cavity, uterine cavity abnormality. It means that we are talking about polyps, synecia, myoma, or adenomyosis. And the third cause, I think that is very important, that endometrial receptivity. That's why with error test, we are looking at the implantation window. So I think that if we can target 3 main causes, we could improve the success outcome for our patients.
I see. Thank you very much for joining us today, for answering the question.